With this, we go to the next presenter. We have Dr. Vinod Sharma, who will be talking to us on beta blocker in HFrEF and HFpEF. There has been some controversy, some consensus. Let's see what Dr. Vinod Sharma has to say. Dr. Vinod Sharma, sir.
Good morning, sir. Good morning, colleagues, ladies and gentlemen. At the outset, I must thank Dr. Chopra, our moderator, and also Afreen and Mr. Murtaja for including me in this academic feast. My two co-speakers have beautifully drawn the entire picture of problem of heart failure and how the things have progressed. How this four pillar of drugs have changed the therapeutic strategy in the patient with heart failure. Already my two co-speakers have spoken about the two important drugs. Now my role is in this beta blocker. Beta blocker in heart failure with reduced EF and preserved EF. As we all know that whenever there is a myocardial insult, there is a left ventricular dysfunction sets in. Then there is a neurohormonal activation. It has one neural limb, another is hormonal limb. Neural limb obviously is operating through the sympathetic nervous system and hormonal limb is through the RAS. Now, this neural limb and catecholamine, they have a set of mechanism by which they produce cardiotoxicity. They bring imbalance in myocardial oxygen supply and demand. They bring calcium overload with subsequent phosphorylation of multiple protein. They increase the oxidative stress. They bring coronary spasm. They cause depletion of energy stored, and they increase the mitochondrial permeability. And that's how the catecholamine has a deleterious effect on myocardium. On one hand, this cardiac and systemic norepinephrine is rising. Simultaneously, this sympathetic stimulation also causes RAS activation, and that operates through the kidney, leading to the retention of sodium and water. On one hand, there is a peripheral vasoconstriction leading to increase in afterload, increasing in the left ventricular wall stress, coupled with increased preload consequent to the retention of sodium and water. That what brings the syndrome of congestive heart failure. There is a progressive pathological changes in the ventricular mass, composition and shape of the ventricle. That's what we call as adverse ventricular remodeling. So we can understand the crux of the issue starts with the sympathetic activation in the heart failure. We all have seen beta blocker. Traditionally, beta blocker was absolutely contraindicated in heart failure 25-30 years ago, and relative contraindication in diabetes mellitus. And considering the beta blocker for treatment of heart failure, it seems to be counterintuitive. How to use this, how to treat a poorly contracting ventricle with a negative inotrope like beta blocker. But beta blocker has continued to surprise us all along last 5 decades. From after a seminal work of Wachstein in 1975, when he started using the drug beta blockers in patients with congestive cardiomyopathy, the beta blocker role has changed from most hazardous drug to the so-called most effective drug in 2022. And in fact, if we look at the 2022 guidelines for management of heart failure, beta blocker has been accorded class 1A indication in the treatment of heart failure. It clearly states that in patient with heart failure with reduced ejection fraction, with current or previous symptom, use of one of the three beta blocker proven to reduce mortality is recommended to reduce mortality and to reduce the hospitalization. What is the rationale of using beta blocker? Beta blocker reduces heart rate blood pressure, they inhibit RAS, they cause reduction in atrial and ventricular arrhythmia, they have anti-ischemic effect, they improve the contractility of viable but not contracting myocardial region in patient with ischemic and non-ischemic etiology, and they have beta blocker have salutary effect despite an initial and transient decrease in the contractility. What are the evidences? Let us look at the evidences. There are series of observational study and multiple trials starting with the 1994 till late 2005. And I would just present the meta-analysis of this randomized controlled trial. What they state that use of beta blocker led to the marked decrease in the incidence of overall mortality, cardiovascular mortality, and sudden death by 34 to 39%. Reduction in mortality in patient with ISD by 30% and in non-ISD patient with heart failure by 26%. And reduction in mortality was greater with the vasodilatory beta blocker than non-vasodilatory beta blocker. And as such, there was no obvious difference among different beta blocker for risk of death, sudden cardiac death, and death due to pump failure or drug discontinuation. And improvement in left ventricular ejection fraction was similar irrespective of the drug studied, and benefit of beta blocker in heart failure with reduced ejection fraction appears to be a class effect. Moreover, beta blockers were used in addition to ACE inhibitor in all these trials, and the incremental mortality benefit which was observed with this beta blocker were greater than those observed with AC alone or with any other class of drug. Beta blocker also benefited the patients who were not taking ACE inhibitor, and patient need not take target dose of ACE inhibitor before initiation of therapy with beta blocker, but doses of beta blocker and ACE inhibitor as far as possible should be maximized in the therapy of heart failure. If we look at the natural history of heart failure and so-called staging of heart failure, from stage A, when there is just a risk factor for heart failure, over a period of time, it may take decades. There is a progressive left ventricular hypertrophy or ischemic insult, leading to a diastolic dysfunction, systolic dysfunction, combined systolic and diastolic dysfunction, bringing subclinical left ventricular dysfunction, and eventually overt heart failure. If we see the role of beta blocker has a role in all stages of heart failure, whether it is a stage A, B, C, and D, and there are evidences. Let's examine those evidence. Patient with so-called stage A or pre-heart failure stage, the patients who have just risk factor like diabetes or hypertension. There's a 42% reduction in risk of developing clinical heart failure in patients who were randomized to beta blocker, regardless of initial indication of beta blocker treatment. And there were some concern with the atenolol. Atenolol brought a pseudo antihypertensive effect. It has an unopposed alpha activity which brought a vasoconstriction, and central aortic pressure was rising. That concern was there with atenolol. Some concern came up with the result of ERIC and LIFE study regarding the new onset diabetes. And it was recommended better to use comprehensive beta blocker like carvedilol or labetalol and nebuvolol in this set of the patient. Looking to the stage B patients are those who have asymptomatic abnormalities of cardiac structure and function, and this stage clinically correlate with NYHA class 1. Development of left ventricular dysfunction is often progressive, and it occurs even in absence of new insult to the heart. We have a data from the SOLVE trial, and if we dug up the data, SOLVE it concluded that there was a significant lower rate of mortality due to heart failure in patient receiving beta blocker in this asymptomatic state. Furthermore, same fact came with the SAVE study. 30% lower risk of death in the patient with stage B heart failure. 21% lower rate of progression to overt heart failure, which was where the benefit was independent of AC inhibitor use. Similar view came in the Capricorn trial. Beta blocker has a role in reverse cardiac remodeling, and there was a statistically significant increase in left ventricular ejection fraction with the use of beta blocker. Moreover, again in the Carmen, the carvedilol and enalapril, they were compared alone or together. As we can see the result from this Carmen 2004 study, carvedilol alone significantly reduced left ventricular and systolic volume index by 2 ml from the baseline. And when it is combined with enalapril, the left ventricular and systolic volume index further by 6.3 ml. If we see the revert, that was a dose of, that trial which studied the doses of metoprolol, 200 milligram group compared to 50 milligram group who received metoprolol had a significant decrease in left ventricular and systolic volume compared to baseline and with the placebo. Stage C heart failure. Those patients who had current or previous heart failure symptom associated with cardiovascular structural abnormality, we have ample data. Copernicus study. It studied more than 2,000 patients. Use of beta blocker in patient with heart failure less than 25% ejection fraction reduce the mortality, total mortality by 35%. The combined risk of death or hospitalization for heart failure reduced by 31%. Copernicus studied the very high risk group. Very high risk group are those who had a recurrent decompensation, more than 3 hospitalization per year, need for IV inotrope and vasodilator within 40 days of randomization, and ejection fraction below 15%. And this study also concluded that cumulative 1-year mortality in beta blocker group reduced by 39%. Patient, they all received the carvedilol. Looking to the stage D, these are the severely symptomatic patients with structural heart disease. They are often dependent on inotrope or device. Rematch study which got published in 2001. In this, if we see the data of this study, only 22% could tolerate beta blocker. We should exercise great care in using this set of the patient. Start with using low dose and monitor for intolerance. But still, attempt should be made to use beta blocker as far as possible. Coming to the set of the patients who need beta blocker. Beta blocker appropriate patients are those who have left ventricular systolic dysfunction, left ventricular ejection fraction less than 40%, those who have mild or moderate impairment in functional capacity, those who are in class 2 or 3, those who have optimal and stable circulation, and obviously there is no contraindication to use of beta blocker. Where we should avoid beta blocker, obviously patients who have heart failure without left ventricular systolic dysfunction, those who have severe impairment of functional capacity class 4, those who are in a decompensated state, fluid overload or low cardiac output, or those patients who are requiring intravenous inotrope or any other kind of mechanical circulatory support, we should not use beta blocker. Question is, which beta blocker? We all know beta blocker have a common class effect of blocking adrenergic receptor, but they differ in their pharmacological profile. Some of them have intrinsic sympathomimetic activity and lipophilicity. Metoprolol and bisoprolol are selective beta 1, while the carvedilol has a wider network. It has beta 1 and beta 2 as well as alpha adrenergic receptor blocking action that gives it additional advantage of peripheral vasodilatation. It enhances insulin sensitivity. So what should be the preferred beta blocker? If we see the overall picture, all the beta blockers are not the same in their effect. Their antihypertensive effect is a class effect, but beneficial effect on heart failure with reduced ejection fraction is not a class effect. Third generation beta blocker, carvedilol, are metabolically neutral and offer complete adrenergic blockade. Carvedilol and nebivolol are the third generation of beta blocker of choice for heart failure, together with second generation beta blocker like bisoprolol, metoprolol, bisoprolol and metoprolol succinate. This is what has come out with all this landmark study, COMET, Caprion, US carvedilol study, Copernicus, and senior and merit heart failure trial. How to start beta blocker in heart failure? Precisely, we have to assess the clinical state of the patient. All patients with mild, moderate, or severe symptoms, we should look for any contraindication, for any exclusion, like cardiogenic shock, sign of systemic hypoperfusion, systolic blood pressure below 85/90, and any absolute contraindication. If they are not there, none of the contraindication, then start the treatment, start the beta blocker therapy with a lower dose, and then gradually titrate the dose. And in between, this patient need monitoring, especially for any sign of hypoperfusion or any sign of shock. To obtain the maximum prognostic benefit, adequate titration is required, and doubling of dose every 2 to 3 weeks is necessary. And we need to see factors which are limiting the up titration of dose, like hypovolemia or concurrent use of any other drug. The standard dosing for this different beta blocker, as it was used in different trial, are the target doses with bisoprolol is 10 milligram per day, carvedilol 50 to 100 milligram, metoprolol up to 200 milligram, and nebivolol 10 milligram. What relates to mortality benefit in patients with heart failure with reduced ejection fraction? Is it the dose of beta blocker or heart rate achieved? If we look at the heart failure with reduced ejection fraction, heart rate is not only a risk marker, but it is a modifiable risk factor. We need to know the heart rate burden in patient with heart failure with reduced ejection fraction. All this trial have concluded that higher the basal rate of heart rate in a patient with heart failure before instituting the beta blocker, maximum is the benefit. How much heart rate can be decreased is more important than how much dose can be up titrated to achieve better clinical outcome. This is a nice meta-analysis which was published in 2009. They nicely correlated beta blocker dose, heart rate reduction, and death in patient with heart failure. And the conclusion was magnitude of heart rate reduction is more important predictor of outcome than the dose of beta blocker. There was a strong correlation between the magnitude of heart rate reduction and improvement in left ventricular ejection fraction, and relative risk of death decreased by 18% for every reduction in heart rate of 5 beats per minute with the use of beta blocker. Another study which compared the mortality of higher versus lower dose of beta blocker, that was metoprolol, succinate, or carvedilol in patient with heart failure with reduced ejection fraction. This study nicely concluded that high doses of beta blocker therapy and the lower heart rate achieved both independently and jointly are associated with reduction in mortality in patient with heart failure with reduced ejection fraction. Next question is, what should be the optimal resting heart rate to be achieved to have a maximum mortality benefit in the patients who are patient with heart failure with reduced ejection fraction who are started on beta blocker? There is a very nice study from the M.B.B.S trials, sub-study, and it clearly, as we can see the graph, clearly the maximum benefit is when we get that heart rate, resting heart rate between 55 to 64 beats per minute. That offers maximum mortality benefit in patient with heart failure with reduced ejection fraction. Let us see a special clinical situation, how to deal with them. Patient with peripheral congestion, those who have fluid overload, ideally we should not start beta blocker. We should look for increased dose of diuretic, look for a fluid management till they dry up. Add second diuretic if there is no response, so as to get a sequential nephron blockage, and initiation or increasing dose of beta blocker should be deferred till euvolemia is achieved. Discontinuation or dose reduction of beta blocker is not indicated in presence of congestion unless it is associated with hypoperfusion. If the patient is cold and weak, then only try to withdraw, otherwise reduce the dose of beta blocker. It should continue. Achieve compensation by adjusting the dose of AC inhibitor or diuretic, and patients presenting with hypotension and sign of hypoperfusion, beta blocker should be discontinued and supportive therapy with other drug should be considered. What about asymptomatic hypotension? Asymptomatic hypotension is quite common in heart failure with reduced ejection fraction, and it is not a contraindication to beta blocker therapy or withdrawing. Look for inadequate preload due to diuretic or vasodilator. Adjust their dose. Adjust the dose and timing of concomitant therapy, and then continue the beta block. What about the patient with symptomatic bradycardia? Beta blocker may be used in patient with asymptomatic mild bradycardia, especially when heart rate increases with exercise. We are free to use beta blocker, and we should look for any drug interaction, especially if the patient is on digoxin or amiodarone. Their dosage to be titrated. Given the substantial benefit of beta blocker in heart failure with reduced ejection fraction, asymptomatic bradycardia during beta blocker therapy is not a reason to discontinue. And in some of the cases, if we see the benefit of beta blocker is more and heart rate is slowing, one can consider cardiac pacing on a individual basis. Now, switching between beta blocker in heart failure, we need to switch sometime. If we look at the entire profile of beta blocker, beta 1 blockers like metoprolol and bisoprolol, they have demonstrated to reduce morbidity and mortality in heart failure. But beta 1 selectivity has certain potential biological disadvantage. Beta 1 receptor density, which is already downregulated in patient with heart failure with reduced ejection fraction, metoprolol reverses this effect, and resulting upregulation of beta 1 receptor density may bring elevation in the central venous norepinephrine level. It leads to the increased adrenergic signals, and selective blockage of beta 1 allows or even accentuates this signal through unblocked beta 2 receptor, which is not only cardio stimulatory but may also enhance arrhythmogenicity. Unblocked cardiac and peripheral alpha receptor, they bring cardiac hypertrophy, they bring adverse remodeling, and they have role in lethal arrhythmia. Alpha 1 receptor increases heart failure progression by causing increase in peripheral vasoconstriction and diminished renal hemodynamics. And therefore, we need to have a complete beta block. Complete degree of adrenergic blockade by inhibiting alpha and beta receptor is achieved. That leads to reduction not only in heart rate and wedge pressure, it increases stroke volume, it increases stroke work. It is superior in improving ventricular function compared to beta 1 selective agent. And carvedilol is the class of the drug. It has, beside the basic beta blocking effect, it has a potent antioxidant effect. It is anti-proliferative, anti-apoptotic, antiarrhythmic, and it inhibits the vascular endothelin production. Lower doses of metoprolol has not been found to be effective, while carvedilol, when used in even lower doses, is known to reduce morbidity and mortality across all ranges of heart failure. Carvedilol may be beneficial in patients in whom the progression of symptom or decline in ejection fraction occurs despite adequate therapy with the maximal tolerated dose of another beta blocker and also AC inhibitor and diuretic. There one can change from metoprolol to carvedilol. Now, certain protocol is to be followed when we are switching. Switching is usually safe and well tolerated. It needs a sound, judicious physician judgment concerning individual patient requirement. Dose of first or second generation beta blocker that patient is receiving is an important consideration. And when switching to carvedilol, maintaining adequate beta blocker to avoid the potential ischemia or arrhythmia should be looked for. And adequate treatment of diuretic and AC inhibitor should be in place, and patient should be free of volume overload before we think of switching over. If the consideration to switch is driven by clinical deterioration and lack of response, patient should be first stabilized with modulating the dose of AC inhibitor and diuretic. Switching over of the beta blocker is not recommended if there is a severe decompensation. We should inform the patient about possibility of symptom related to alpha blockade, that is vasodilatation, and separate the dosing timings of carvedilol, AC inhibitor, and diuretic by at least 2 hours. During this switching over, do not add any other vasodilator, calcium antagonist, or nitrate during the switch. There are two patterns. We can overlap the doses of one beta blocker with other, or we can choose a non-overlapping beta blocker. A comparable dose of one beta blocker can be adjusted with the other beta blocker. Sometimes we need to switch from carvedilol to beta 1 selecting agent. Situation like hypotension due to alpha unblocking effect of carvedilol or unmasking of reactive airway disease due to beta blocking property of carvedilol. There we need to switch back to the metoprolol. There are special situations. There are many concomitant conditions where beta blocker and comorbidity, there is an interplay. Patient with hypertension, choice is obviously carvedilol and nebivolol. Patient with asthma and obstructive airway disease, one should choose bisoprolol or nebivolol. Patient with diabetes, we should use beta blocker which enhances insulin sensitivity like carvedilol. Patient with atrial fibrillation, the metoprolol AV nodal blocking effect, lowering heart rate is probably more than any other, so we should use that. Patient with peripheral vascular disease, choose carvedilol or nebivolol. Patient with hyperlipidemia, again, carvedilol being metabolically neutral is a choice. Patient with hyperthyroidism, where our prime motive is to control heart rate, metoprolol is choice. And not to forget, a lot of patients have erectile dysfunction and there is concern about use of beta blocker. In them, first choice is nebivolol or bisoprolol compared to metoprolol or carvedilol. Now, patients with heart failure or on ACE inhibitor, beta blocker, now newer two more drugs, question often comes when we are seeing the new patient. Is it an ACE inhibitor or beta blocker? Which should come first? Let's dig into the pathophysiology which we saw in the beginning. Myocardial systolic dysfunction is because of neurohormonal activity. That is compensatory mechanism to preserve the cardiac output. Neuronal limb is obviously sympathetic system, while the humeral limb is RAS. Sympathetic nervous system is activated even in mild cardiac dysfunction after a small increment in left ventricular filling pressure. But plasma renin activity system, RAS, that is activated with severe congestive heart failure in symptomatic patient. So in chronology, it is the sympathetic activity which comes first, followed by the RAS. So by logic, beta blocker should come first. Heart failure is a hemodynamic as well as neurohormonal condition. No doubt it can improve with the vasodilator. Adrenergic system is activated earlier than the RAS. Enhanced sympathetic activity that itself may lead to the enhanced sympathetic renal activity that may contribute to the sodium and water avidity. There is a less escape and greater suppression of angiotensin II by ACE inhibitor when the adrenergic system is also blocked. This point we have to note. And cardiorenal complication of heart failure may be because of rise in serum creatinine with ACE inhibitor. That can be decreased by pre-treatment with beta blocker. More so, beta blocker have greater impact on left ventricular remodeling than ACE inhibitor. And in contrast to ACE inhibitor, beta blocker have greater impact on lowering the risk of sudden cardiac death, which accounts for more than half to two-thirds of mortality and heart failure. And lastly, we should remember, beta blocker do not provide a hemodynamic rescue for the acutely decompensated patient with volume overload and low output. So we have to choose beta blocker, keeping this point in mind. According to guideline, ACE inhibitor is initiated first, followed by beta blocker after a variable time, depending on the clinical judgment. Let us look at the data from CBS-3. CBS-3 clearly stated that initiating therapy with bisoprolol followed by ACE inhibitor was similarly efficacious, and bisoprolol arm had a trend towards better survival and preventing further worsening of heart failure. Now, coming to this issue of heart failure with preserved ejection fraction, my two co-speakers have nicely briefed that it is a heterogeneous disease, but multiple associated comorbidity. What we have to understand is that in patient with heart failure with preserved ejection fraction, common denominator is exercise intolerance with which patient comes to us. If we look at the FICS principle, basic FICS principle states that the increase in cardiac output during maximal exercise can be predicted by synergistic response of stroke volume and heart rate. And in a healthy subject, exercise raises heart rate by 2.5, while stroke volume increases only at 1 to 1.5 fold. So by this definition, contribution of heart rate is more, and contribution of heart rate abnormality to exercise tolerance in patient with a small and stiff ventricle is much more. This is the problem in patient with heart failure with reduced ejection fraction. This is one of the study where they try to pace the atria. Now, when we are pacing the atria, we are increasing the number of systole and decreasing the duration of diastole. As a result, the ventricular filling is reduced, and that reduced ventricular filling lead to the reduced volume and reduced filling pressure. With this thought in the mind, this pressure HR study, which was a beta blocker withdrawal study in patient with heart failure with preserved ejection fraction and chronotropic incompetence, they assess the effect on functional capacity. This was a study with a small number of patients, and they were randomized to have their beta blocker discontinued or maintained over 15 days, and they crossed over to either withdrawal or continued thereafter. The results showed that after stopping beta blocker, patient had improvement in their exercise tolerance, peak VO2 increased by 18%, and secondary endpoint like quality of life, which was assessed by Minnesota scale, had a significant improvement. And the author of this study nicely quoted that probably we are learning by using beta blocker, we may be doing harm in this patient with heart failure with preserved ejection fraction. Evidence as on today for utility of beta blocker in heart failure with preserved ejection fraction simply is inconclusive. Recent meta-analysis of 11 trial did not demonstrate any benefit of beta blocker in heart failure with preserved ejection fraction. And beta blocker use in patient with heart failure with preserved ejection fraction needs profound re-evaluation. Just to conclude my talk, as we heard with the previous speaker, this 4 class of drug, ARNI, beta blocker, MRA, and SGLT2 inhibitor, no doubt they form 2 strong pillars of management of patient with heart failure with reduced ejection fraction. But as far as patient with heart failure with preserved ejection fraction is concerned, we need a profound re-evaluation. Probably it is a time to slow the beta blocker use in patient with heart failure with preserved ejection fraction as the result of preserved heart rate 2017 is concerned. Rather, they also concluded that time has come when we have to untie the knot between the heart rate, exercise, and beta blocker in patient with heart failure with preserved ejection fraction. Before concluding my talk, I would like to state that there is a 3 basic key concept of using beta blocker in patient with heart failure with reduced ejection fraction. It should be a compensated patient, it should be a controlled dosing of beta blocker, and it should be a constant clinical supervision when we are using beta blocker in patient with heart failure with reduced ejection fraction. Thank you, sir.
Thank you very much, Dr. Vinod Sharma, for your brilliant presentation. I think the way you described each stage, A, B, C, how we give the beta blockers based on the scientific data infected logistics. And I think you mentioned very rightly, it is the target heart rate which is more important rather than the dose. And you also highlighted on the role of chrono incompetence in HFpEF. I think there has been a lot of data coming up recently, and we have seen in last consensus also by Dr. Terry Nair. He gave a very nice slide showing that the mortality benefits are not there with HFpEF as compared to HFrEF. I think very well explained. And I think you also mentioned the heart rate should not be seen only at the baseline, but also postural variation and even the variation with the stress should be considered so that we can give the maximum benefit to the patient. Thank you very much, Dr. Vinod. We are going to have a discussion very soon